Oh yeah, hello.
The first
Okay.
case,
Yeah, you can start projecting. We are done here.
okay. The first case that we have for today is of 48 years old female who presented to us with history of epigastric pain and weight loss for 1 year and obstructive jaundice for which ERCP was done 2 months back. Her CT scan shows a lesion of 2.6 into 2.3 centimeters infiltrating the head of pancreas and uncinate process.
All right.
Now, the first structure, you would just want to pull back to G junction, see how far you are endoscopically. Okay. And now you go, if you basically turn clockwise, you should typically go towards, you can, what you can do, एक चीज़ मैं I'll just show you again, like yesterday. So just relax, step back a bit, and then have this as straight as possible, so that you have freedom of movement of the scope. Okay.
This will be, we have to look for the aorta.
Exactly. So you're at G junction. You're going to look, if you, so basically your probe is looking down like this. So if you turn, you'll get liver, aorta, and then you can identify the branches of the aorta. And if you can't see it, come back, because you will be able to see it from the mediastinum, if nothing else. So you come back and you repeat the maneuver again. There you go. And now try again. So now it's spinning the scope. So now we're starting to see familiar structures, right? So now let's go back the other way. Let's go counter. There you go. And keep, the big wheel is important, this apposition against that wall, so that you have the probe against the wall so you can see your structure. So suction and then big, wheel towards you, come down. There you go. Now you have liver. And if you go clockwise, you start seeing liver. If you keep going clockwise, keep going clockwise, keep going clockwise. And now, what's the structure?
Right again, right?
Now go counter again. Go counter. And that long tubular structure.
Right.
So pull back a bit for a second and so go clockwise. Okay. And air है, ये artifact है इधर left. Go counter करें जरा, other way. So now you're seeing structure. So they're somewhere in this area, right?
Yeah,
So
okay.
now you know that you have to move in this zone. So now you're starting to see a large structure giving off a vessel. So how about pulling back a bit? If you see vessels above, usually that's not the celiac, because that's already branched by this point. So what is this?
That's the aorta.
Very good. So now you have identified your aorta right here. So now you can go
further down.
You can go, just go clockwise and counter. Just see if you can see the branches. Okay, now you saw something come off right there. What do you think this is?
Celiac,
Excellent. So that's the celiac.
Right.
And now now that you have the celiac, you see potentially, oh yeah, that's okay. You can always pull back, right? It's a dynamic study. So we're moving all the time. So pull back, find your aorta again, identify your aorta. Maybe we need to pull back again and go clockwise or counter. What do you think? Relax your big wheel and so I think you went all the way actually clockwise to the spleen. So if you go counter here, you might come back towards aorta. Yeah. अच्छा. So क्या हुआ है?
अच्छा,
What's this?
अच्छा, ठीक.
ठीक है now.
हाँ, ठीक है.
So
Right.
now push, advance your scope a bit and spin over the aorta. Keep the aorta in view. So what you want to do is spin so that you don't lose sight of the aorta.
हाँ, ठीक.
ठीक है? Now what's there you go. What's this now?
Celiac,
Okay, I'm going to freeze it one
Yeah, okay.
second. हाँ जी. Oh, अच्छा sure. कर लें.
अच्छा, अच्छा, ठीक है. हाँ, हाँ, ठीक
करें,
है.
करें. We हमें बस cable change करनी है, so there's going to be a gap for 30 seconds.
चलो ठीक है.
Can you hear us? उनको आवाज़ भी जा रही है कि नहीं? अच्छा. Mic.
Yes, we can.
Okay.
We can hear and see you.
Okay. So there's going to be a pause for about a minute or so.
Wasim कहता 30 seconds, so he's under pressure now.
तो ये है आपका
अच्छा, ठीक है.
aorta. This is the celiac,
अच्छा,
and this is the crest of the diaphragm.
ठीक.
ठीक है? Now, if from here,
Mhm.
if you go clockwise, you're going to the patient's left.
Right, okay.
Okay? So what you want to do is not stand actually like this, but turn your body a bit like this.
Right, okay.
So you orient yourself. You're here.
Right.
If you go clockwise,
अच्छा, so,
you're basically back. You're facing the back.
right.
If you go clockwise, you're going to come towards
Come
the patient's
towards
left. So you'll see spleen
Green
adrenal,
left kidney.
and left kidney.
Yeah.
If you go counterclockwise,
Right, okay.
you will go towards
the
liver
Right.
and pancreatic body,
Right.
head, neck.
Can you ask what about you?
How's the view now? The EUS view.
अच्छा.
Yes, we have this view.
Okay, is it like I don't? Is it better or is it the same? Go the other way now. Is there any change in the quality of the view or the same as before?
No, I think it is the same.
Okay. चलिए
वो वही हाँ सर.
चलिए light off करते हैं. Okay, so let's. So you're now really
Okay.
clockwise. That means you have spleen,
Right.
right? So if you go counter here,
Right, okay.
you will get away from spleen.
You need to get the aorta.
Yeah. So see if you can find the aorta again. Yes. There you go. There you go. Okay, that's good. And now keep pulling back because to identify
Yeah.
the branches, but keep it in view. So spin over it to see just small movements left and right to see which way it's going.
Yeah.
Okay, so there you go. There's your branch coming off to the left of screen.
Yeah.
So you may need to advance a bit more, right? But keep the aorta in view. So do whatever it takes to keep that aortic view. So do you maybe need to thumb down a bit and then go counter? I think you may have advanced a bit too, but go counter and then pull back a bit. There you go. So और थोड़ा सा करें and that's it. There. Now you have this. Now advance, keeping this in view, gently advance. There's your celiac coming off.
Right. Okay.
Okay, there's the crest of the diaphragm.
Right.
Now you advance and you want to follow the celiac. Beautiful. This is exactly what you want to do. Follow it. And then the branches are not, unless that's already SMA. Yeah, that's actually following the SMA.
अच्छा,
So
ठीक.
pull back,
Right. Okay.
pull back, because you already have the branches of
Right,
the celiac above you. Now the other thing is, I mean, you can follow the artery or you can identify your structure,
अच्छा, ठीक.
which is, what's the structure? Can you see what that is?
That is pancreas.
Yes. So now that you have the pancreas,
Right, okay.
now you have a sense for where you
Right,
are.
okay.
You what if an image is to your left,
Yeah.
you need to advance your scope a bit and bring it into your center. If its image is to your right, you need to pull back to bring it in. Now that you have the pancreas in the middle,
Right, okay.
now you can just follow,
Right.
determine if this is your duct or not.
Right, okay.
You can just by doing flow or not. So
Yeah,
this
so
looks
that's
like
the
duct,
duct,
right?
yeah.
So now that you have the duct in view, you can just say that I'm going to follow the pancreatic duct. And here, if you go clockwise, it'll take you towards the body tail. And if you go counter, it'll take you towards the head. So now exactly that's it. Keeping that pancreatic duct in view, that's your reference point.
Right.
And you're going to follow. So if it's falling away from you here to your right, then that means you need to pull the probe back. So pull the probe back, and now it becomes in the center again.
Right.
So keep pulling back to keep it in view. There you go. Keep pulling back. There you go. Keep pulling back as you follow it. That's it. Excellent. This is you're following the pancreatic duct all the way to the tail.
Right.
And what's interesting is below you, let me just freeze this because your eyes were focused on that, but you also encountered the left adrenal. So this is your left adrenal gland,
Oh, I see, right, okay.
right, the seagull appearance.
Right, okay. See that?
And then the kidney is on your left
Yes,
screen,
right, okay.
and then
Where
the
the
spleen
is.
would be down here.
Right,
So now that you follow the pancreatic duct, there's your adrenal. You're sitting right on it,
Right.
and that's the spleen there. Now you can go the other way to follow the pancreas towards the neck and head. So now go counter again. There, and now you may need to again advance the scope to see if there you go. There's your pancreatic duct, and now if you advance, I'm going to just enlarge the image for you a bit. There you go. Or maybe that's too much. Okay. Now, yeah, so pull back a bit because we may have lost the pancreatic duct there. Now go clockwise. That may be the duct, or that's vessel. So let's figure out where our pancreatic duct went. So go counter. There it is. Okay, so now we have our duct in
Okay,
view.
fine.
So let's pull back a bit to bring it in the center. And now go counter because we want to follow it towards the neck and body.
Right, okay.
There you go. Keep going counter. Excellent. Keep going.
Yeah.
And now it's dipping down. So
Yeah.
when it's dipping down, that means from this part, the proximal stomach, this is as far as you can see.
Oh, I see.
If you want to see more of the duct, you may have to advance a bit, suction the stomach out, turn into that posterior wall again, and see that if by pulling back, if you can see the pancreatic duct. That isn't essential at this stage early on, because most people, at this stage, they're taught to just follow it as far as you can take it,
All right, okay.
and then go to the bulb and do your second sort of next. So what I would
In
suggest
stomach,
is,
how far do you go? You look at there.
yeah, about here. Up,
Right.
You can go to the pyloric channel
All right,
suction,
okay.
turn clockwise towards
I'm
that
quite-
back wall.
so
You're
I
quite a
was
ways
there.
in,
I
right?
was quite a-
Yeah, and now you can pull back. So you'll start liver, and as you pull back, you start spinning left and right,
Right, okay.
and eventually you will get suction because you need to keep it completely decompressed. Turn into the back wall, and now as pull back and go counter and clock, and that'll show you the pancreas. So that's liver. So maybe we need to go more clockwise because liver is higher up, so we need to go more clockwise. Yeah. Pull back some more. Section. Yeah, but just pull back. I think we're too far in as well. So right there, and suction and turn into the back wall. So turn clockwise. So now this may be where the pancreas is. So pull back a tiny bit more and go counter. Now go counter. So there's your compass. This is that view that you were saying.
Yeah, right.
So now you have the splenic vein going in. So there you go. So that's okay. You can advance a bit because it's away from you. So advance a tiny bit. There.
Okay.
Splenic vein going into the portal
Portal vein.
that'll go down towards the liver.
Yeah.
And then you may see the bile duct below here too. So advance a tiny bit and spin over that area. So and the pancreatic head would be down here in this view, right there. So just spin over that area. Go. There you go.
Right.
Okay.
Right. Okay. So
Okay.
that's the confluence.
Yes, that's part of the conference. I
Conference,
think
yeah.
we're not seeing all three vessels, but you're on that same track.
Right. And where would I expect the bile duct to?
Be behind. So portal is going to go down this way, and bile duct will be down below it. Okay. Just go counter a bit. You might see the go the other way. The counter. Oh, I see. Section. Let me just quickly
Yes.
do this.
Yeah.
If it works or not,
Yes, yes.
because it doesn't always work. That maybe SMV. That's A. That's V, perhaps. There.
Where?
Let me see. So it's actually this here. So we were actually looking at the wrong vessel. So this is your confluence.
Right. Okay.
So now what you have is
Yeah.
SMV going in. If I turn here, you may see SMA as well. There's SMA,
Right.
thicker wall,
Yeah.
narrower, SMV.
Right. Okay.
This is the confluence.
Yeah.
And actually, I think this is her pancreatic duct, which is further dilated here up in the, oh, wrong one. See, this is the pancreatic duct.
Oh, I see.
There's the confluence. And the duct here goes from body, tail, coming down towards head. As you look down, the pancreatic duct is going to dip this way. And
Right.
this is your mass right there.
Right.
And your bile duct and portal vein are going to go this way. So there's portal vein,
Right.
and bile duct should be behind it, which should have a stent in it. This might be it, right there. So you
Oh,
see
yeah.
that?
Yes, yeah.
So right there,
Is the bile duct.
there's the bile duct stent outline right there.
Right.
So this is your
from-
so this is in the stomach.
Yeah.
Go ahead.
In the stomach, how much of the bile duct are you expected to see? I
Yes.
mean, do you assess it from here? or
You
do
don't
go through-
typically assess it from here.
Oh, right. So you have to go to the.
Yeah.
This is
for-
mainly for the
this
pancreatic
is
mass.
exactly, but
Alright.
this is usually later in like
Right.
your development. You look for this, but
Right.
honestly, I wasn't taught this much, so that's why in my development was later on. But there's no harm in learning it. It's good to
No.
learn it early.
Right.
So, but basically, your portal is going to go down this way, the bile duct's going to go this way, liver is
Right.
going to be up here.
Right.
Your pancreatic duct and your bile duct are then going to meet down this way,
Right.
and then you'll get the pancreatic head here. Okay, so how about we move forward to now the bulb? Okay.
Okay. Right. So you go endoscopically, yeah?
Yes, absolutely. Just like ERCP, you're aiming, to do the sunset view, and go from there. इनका FA नहीं करना होगा आपको. The 22. Okay, good. Now you're in bulb. So now again, different approaches work for different people. For me, it works best to look and follow the ducts right away. So usually it involves your A, recognizing structures, but B, I tend to go counter a lot in towards the liver right away. And as I do that, oftentimes the portal vein will come into view. Yeah, you may be falling back, so you may have to just gently advance, suction, and then counter, and drop your left hand as far down as possible. There you go. And right away, you see this anechoic structure. There you go. It slipped a bit, but you had it. You actually had right kidney and right adrenal, but that's okay. So let me show you if that's okay. But you basically go in, and it's small movements. So you stable, just relaxed, dropping by extending my big wheel, going counter, and as I get my liver into view, just a few things for the.
Right. So that's the liver.
That's the liver.
Right. Okay.
but the scope is not very stable. And then typically, as I there. So a few things here, what you're seeing is, when you see these hyperechoic foci in a patient who's had an ERCP, that's telling you there's air in the biliary tree.
Right, okay, fine.
Okay, so that's air.
Yeah.
And then as we go clockwise, it's not working out in her. There. As I pull back and go clockwise, right here is your biliary duct. It's not as clear in her as or convincing. There you go. Okay,
Right,
here.
okay.
So there's a lot of air, exactly.
Yes, yeah.
Portal vein, so bile duct with a thickened wall, which may be in post-inflammatory stenting, and a lot of shadowing for air. You have the portal vein here, and now I'm going to try and keep that as my central focal point, and follow it down towards the head of the pancreas. As I do that, the air might get in the way, but right here, this is the bile duct. We're following it down.
Right,
In her, it's not as crisp as sometimes it is.
right.
But what I would suggest here is, just like you normally do in ERCP, go to the second portion.
Yeah.
Now remember, we're suspecting a pancreatic mass, so there may be duodenal altered anatomy, and then so big wheel towards you, just like ERCP. Okay, this is again oblique wing. There you go. And now, excellent. Okay, there's your stent. And so you have a good target to look for when you do your ultrasound image.
Right.
So now you reduce just
Dr.
like in
Mustafa,
ERCP.
can you hear us?
Yes.
Can you just please brighten the picture? We're not seeing, we're seeing a very dark picture here.
Right now we're not really don't have much, but sure, I can generally brighten it.
Yeah, there's a stand.
Sorry.
And we do the same, right?
It gets very, we get a lot,
Oh, okay,
a
okay,
very,
okay.
very
Okay, okay.
bleached
Okay,
image.
okay.
So we may have to lower the
All right,
gain.
all right.
So now come back to the papilla.
Yeah, you can come back to papilla. Now, again, thumb down, so you're getting apposition
आप में
against the
से
papilla.
अगर वो वाकई मतलब this picture is not good, but you want to go and stand there.
I will brighten it in just a second, once we have apposition.
Okay.
Let's, to see how that looks for us as well. Okay. So yeah, so now that you have that roughly in view, small wheel to the right, excellent. There you go, and thumb down again to get more against the medial wall. And usually this is like in ERCP somewhat unstable, so turning to your right stabilizes you. Now this is taking you very far, so you'll have to do thumb up some more, thumb down, sorry, to get more closer, reduce some more. That's okay, you're still reducing. There you go. Okay, now that you've reduced and you're rightwards, now you can gently withdraw the scope and sort of hug the duodenal sweep, and then, or the duodenal second, third portion, and then pull back. So we're looking endoscopically here. You can see that you're still away from the wall, but that's okay. As you pull back, the probe will get opposed to the wall. You've fallen, yeah. Do you want me to show you just
Yes.
one? Okay, and then we can definitely do it. So here, again, just like you did, the right wheel to the right. Let's see, where is our stent? So this is our stent. So I'm going to visualize where my stent is, typically advance just a bit, and thumb down. And right away we have mesenteric vessels. And then I'm going to, because my probe is against the wall, I'm going to start gently pulling back. How is the image quality for you right now? And as I pull back, this is straight. I tend to drop my left hand down. that stabilizes you further. There's the aorta.
Yeah, it's a little better.
Let me, I'll increase the gain.
Yeah, okay, okay. Whatever is optimal for you, yeah,
Okay.
we understand that.
Okay. And now as I pull back, we start seeing the pancreas come into view. I'm going to make it a bit larger because this is our area of most interest. So there are the mesenteric vessels. And now as I go, these are my movements. Now at this point, my clockwise encounter are either with my right hand with the scope or my wrist or with the right hand supporting it.
Right.
And basically I'm doing small movements. These are like less than 45-degree movements just to see the area. So there, the pancreatic head came into view. This is our mass right there with the stent traversing right through it. So if I just freeze it, that's our stent. You can even make out the stent, and then this is the lesion. And then if you spin over it, you can see the lesion with the stent and air within it. Behind it here is your pancreatic duct right there. And to ensure that it's not a vessel, we can always put flow on it. Oh, sorry, wrong one. To see that this is a anechoic structure, which is a duct. So here. So once you get comfortable with these maneuvers, you can basically free one hand and do this single-handedly, like this. It's just figuring out what it takes to get into that position. Okay, so in the interest of time, I'm going to do the FNA, and then we'll have you take a look at this area too, okay? So needle up, de दें जी.
What needle?
22 pounds. Okay. और stylet कितने पे है? हाँ सही है. 1.5 पे सही है. Usually, I have it with the olymposcope around 1.5, and then basically look for the एक यार रुको, मैं क्या mass measure कर लूँ पहले. हाँ 18/17 सही है. एक से मैं आपको बताता हूँ, मैं इसको live कर दूँ. And then I'm going to look for my needle tip. So here I tend to actually magnify more just to get closer to see my needle. Right now I don't see my needle. I see some movement at the right upper corner, but I actually don't see the movement. So what I'm going to do is push the stylet out some more. Now I can see it shadowing with my elevator. So now that I have that in view, I'm going to look for my mass again. Right there. Oh, there's the stent. Now you can see it very clearly in cross section. And there's my lesion.
Dr. Mustafa?
Yes.
Sir, how much the stylet should be out?
You just don't want it poking through. This much is fine. You just get a sense for when you start pushing it too far, I'll show you, it'll start indenting the tissue. So that it tells you that you're too far out. Generally on the Olympus, it's about 2 centimeters. The Pentex, you actually have to have it at 0. The Pentex scope is slightly shorter. It also depends on your location and how your stent and your scope is maneuvering. So there's no fixed rule. It depends on where you are and how your things are lining up. So go ahead and आप ये निकाल दें. Let's take out the stylet और फिर section लगा दें. But on ना कीजिएगा. Now you see how things are moving with your respiration. Sometimes with small targets you have to time your needle puncture with the breathing, and so those with smaller lesions one has to be more precise. Here we have a bigger target. Generally speaking, the periphery of the target in a larger region is more preferable, but you don't want to compromise on getting tissue than looking for the periphery. Here I think this area is reasonably fine. And then you just do a sharp jab into the lesion, gently advance it further, unlock my suction, and do about 15 to 20 passes. We may be too far close to the periphery because but I think we're okay. We're in the lesion.
How many passes do you make, Dr. Mustafa, in a single go?
About 15. I didn't count. I was focusing on the area, but generally speaking, about 15. No more than 20, because your return goes down. I just noticed in the needle that there was a bit of blood, so we'll see how bloody this specimen is. The more you do, obviously, the more bloody it'll get. So what I would like you to do right now is, since we're already positioned and we're going to wait for them to tell us, take over. And so a couple of things.
Yeah, okay, fine.
People come from this side
Right.
and this side.
Yeah.
I feel that this puts strain on you. Other people say that they can support it, but my preference is to come from this side. But everybody adapts their own sort of technique for this. So I'm going to zoom out a bit, and then you can just, again, so not too far in. Hold it from where the bend occurs, right there. And then
Dr. Mustafa, for advocacy, you have got rose technique or what?
at my institution, we have rows. So here, it's I think.
We have got rose, I think.
Yeah, so we're doing rows here. But generally speaking, at our place, we do have rows. Our pathologists work 9 to 5. So if I have a case before 9, I don't have rows. And then I'll take a few passes and put it in formalin and send it off. That's just the way it is. And if it's after 5, it's the same thing.
We actually, Mustafa, it's Saad.
Yes.
We have our technicians and ourselves. We do
Yes.
this evaluation ourselves. And what we are basically looking for is, I know you guys have your cytopaths and they give you
Yeah.
the diagnosis also almost instantly.
Yes.
But what we are really interested in is just seeing whether we've got adequate material or not. For that, we don't really need to, it's a very short learning curve, and anybody and everybody can, I'm sure, do it. Things that I hated when I was in medical college looking at slides, I kind of enjoy them now.
Enjoy
And I
now,
also
yeah.
it also makes sense to me for the first time.
Yes. Now, I will say that you're absolutely right. And as a principle, if we can train ourselves to look at the slides, it's better. What I do is, with our pathologists, they have like a multi-head microscope, and we'll look at the slide together. But you're absolutely right. One doesn't necessarily need to have them in the room.
I can't take it away from Shaukat Khanam Hospital and Asim Yusuf, who were a great help, and they were the ones who were doing this, and I got their tech for a week
We're
into
further.
our unit, and then he came and trained our techs, and then we started looking at it, and
Let me get
they
to the
gave us feedback, and it worked.
Yes. No, that's
I
excellent.
think Khalid's unit in Florida also does a very nice workshop. It's a 2.5 hour
Yes.
workshop that they do for this particular thing, and that was also very useful.
Yeah.
I think once you're doing it, if you go back and see them, that was also
Absolutely.
very. I don't know what Amjad your experience is, but before we started doing rows, our path, FNA
Rapid
results
on-site
or yield was
evaluation.
really not impressive at all. It was depressing, and so you obviously needed to make so many passes, and you didn't know whether you got
I'll put into
blood or
position.
what.
Thumb is
That's
down.
completely changed. We're
And now
almost 90%
generally
plus
this gentle
now
clockwise.
with our
and
cellular
counter.
material.
So thumb down. And I'm actually going to lock it here, okay? We say don't lock it, but right now it's locked to stabilize you. So I assume that I need to go look at the slide to figure out what we got. Stay there.
Right,
I'll be
okay,
back. Okay. कैसा है जी? Blood? अच्छा ठीक है मैं एक और ले लेता हूँ अपने को। So they're evaluating it still, but it may not be the perfect pass. So we'll get another one. Yes. Thank you.
तो जरूरत नहीं लगता नहीं वो डालने में रीमा क्या वो तेरी जा रही शायद वो
The other approach would be to see if I can find it from the bulb. So this is my bile duct.
दोबारा
There's
निकाल
a
के डालो
stent in it.
दोबारा निकालो
As I go
बाहर निकालो
clockwise, there's the the biliary stent in cross section, and that is the area of the lesion. So it's off to my right, so I have to pull back my scope. But if I pull back too much, I'm going to fall back into the stomach. So I have to just gently see if I can figure out a way to stabilize here. But this is going to be the lesion right there with the tumor. So maybe this time we can go across in the bulb. The most of it you actually see best from the second portion.
Do you normally ask your assistant to hold the scope when you're in the position when you are doing
No, usually I have, I'm a control freak,
Right,
so
right.
I have full control of the scope. If it's a very unstable position and
Right.
I do need somebody, the problem is when you have a certain angle at which the scope needs to be rotated, it can be very hard for the other person to know
Exactly.
which way to go. So I personally tend not to do that, but
Right.
obviously there's no harm in
I mean,
doing
some
it.
people, yes.
Yes. So I prefer this second portion
Right.
approach, so we're going to do that.
Haji,
Needle,
needle
Needle
कहाँ
दे
तक
दो
पहुँची
भाई।
है?
उसमें से वो हवा से कर देना था पुश, हाँ वो ताकि कोई क्लॉट श्लॉट ना हो। एक सिरिंज दे दूँ, बाहर करना है या मैं अंदर डाल दूँ? एक सेकंड, ठहरिएगा। So we're just making sure our needle tract is not plugged up. Okay, good. So now we're going to go back. So the other way to figure out how much needle to advance is to look endoscopically. You can see with my elevator movement how far my tip is. What happens in these duodenal positions is that sometimes the needle gets stuck because you're in a bend. And then when you advance it, it suddenly shoots forward. So you just want to make sure that it's a nice stable position, not too far out endoscopically, about this much. And then you can lock your stylet. Yes, please. The Boston Scientific dials are not the best quality dials because they fall off like I just did. So, but you'll find it. Thank you. But all FNA needles are pretty much equivalent, so it doesn't really matter which one you use. वो उसके अंदर अड़ेगा तो फिर ही होगा नहीं 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 इसी से करेंगे एक सेकंड इसमें ना वो कई दफ़ा बस सही है आई थिंक इट विल वर्क तो थोड़ा सा प्रेस करें आप और साथ ये अब हुआ है दैट्स इट थैंक यू This time I might go right across the stent. Right, which is fine. I mean, that's not a big deal, but having a hard time seeing my needle right now, but I can maybe make out the indentation a bit. There we go. Okay, so there's okay, so so that was 15 this time. आप इसका ना करके जिस मुझे नीडल वापस है I'll do one more साथ में ताकि टाइम जाए तो अब आप देखिए मेरे मेरा जो टीचिंग अपने फेलोज को होती है that I want you to point in that corner. This is not, again, everybody's style is different.
Right.
For me, this is the most stable position in the second portion.
Right, okay.
Point in that corner. I tend to have my screens here,
Right, okay.
so I don't need to turn this way.
Right.
And then have the scope like this, and you can be far from the patient.
Right.
And then just gently spin, and you can clearly evaluate the whole of the second portion, like that area of the tumor, right?
Right.
And you can see the stent traversing the tumor. So why don't you take, again, I'm going to lock it, because this time I just want to keep it in position for you. And all I want you to do is go clockwise and counter, just to spin over the tumor. That's it. And then, there you go. See, and now go, keep going counter, keep going, it's okay. Counter will take you towards bile duct. So keep going counter, keep going, keep going, keep going, there. That's the aorta behind you.
Yeah.
Now go clockwise and go the other way. There you go. And as you go clockwise, you should see the pancreatic duct in the bottom.
Right.
So then let me take over. एक और कर लें ताकि
Okay.
we can move on with our cases. कुछ नहीं था. हाँ, that's what I heard. What about this? Thank you. And then how about this one? Okay, I'll just do another one anyway. Yes. So the first one did not give us much in terms of cellularity. So we'll see what the second one shows, but in the meantime, we're going to do a third pass.
Resection done?
बंद अभी बंद से मैंने अभी नीडल नहीं मारी अंदर so so this time because I'm not doing very well with the peripheral, at least on the first pass I'm going more central, and I might be going through the stent, so I have to go a bit firmer.
Okay, so your fanning technique out there.
Fanning, I did a bit of that. You basically use your elevator up and down,
Oh, I see.
or your big wheel up and down
Move the.
to change the angle of the needle. So you leave the needle in the lesion,
Right.
or bring it to the periphery of the lesion, and then change your angle,
Right.
so that you do it in different planes.
Right.
It works, but not doing fanning also works. So it's okay not to do it. Good. So you have that there. And I just want you to practice this spinning back. And so generally speaking, the counter is towards bile duct, and if you go clockwise, it's towards pancreas. So this structure to the right, which is anechoic, is your dilated pancreatic duct, which is this.
Oh, I see, right.
This here. Let me go 8 seconds. But see how that is.
And in a certain measurement, if you have that
बहुत ही
measurement,
बढ़िया
and you
है।
feel you've got tissue, then you're fine. Now that's very, even more subjective है, उसमें थोड़ा subjectivity कम है। नहीं अभी वो वाला wait कर रहे हैं, second. This is I just wanted to show
But
that
the
from
third one
yesterday.
was very bloody too.
I think
We'll
that's a
see.
very, is it a very vascular?
Maybe, yeah, I'll see. But I think we'll have it in the final.
These are lymph nodes. Yeah, these are lymphoid cells. So what we need to tell them is that we've seen cells, and there are lots of cells. So we've got cells now. They will tell us what cells they are. I'm not a pathologist.
Is this that lady from yesterday जो मैंने किया था या कोई और वाला?
Huh? कौन सा है?
जो आप दिखा रहे हैं, वो जो कल जो मैंने किया था या नहीं किया?
No, not
वो,
that one.
can you give me feedback on that lady?
I'll give you.
That, okay, I'm curious to know what that shows.
This is another one. I'm not sure. Like a pathologist, then that makes life much easier.
You're right.
Focus fill in, I don't know whether I do that. But at least I can say
So we're still waiting, Khalid. So that's your mesenteric vessels.
That's right.
Yeah.
I was just looking at that.
So that means you're deep. So pull back a bit and now go counter and clockwise to identify pancreas. Usually you go counter more, I think. So the other thing is there's no harm in falling back in the stomach.
Right.
The worst that'll happen is that you just have to go back in the duodenum, reposition, and start all over. So, so what you want to do is, no, that's fine. If you're there, that's good. So, but my point is that those movements, the counter and clockwise, they need to be large enough for you to actually scan the area properly. Hitting a vessel, that's okay. So pull back a bit more. And come down, yeah. It's more of an EUS, like an ultrasound image, so I wouldn't worry too much about that. Now, come down. There you go. There's your stent. And then hold it from here. Yeah, just you relax yourself. There you go. And now go counter. Other way. Try the other way. If you don't see it, then go clockwise again. Withdraw your scope about a centimeter and do the same thing again. And go counter again. Okay, so that was a give that you probably spent for third to second portion. Or bulb maybe. But it's okay. You keep going, because you may not have. So that's, I think you're still in good position. You're fine. So don't worry about that image. Concentrate on this image. So ultrasound image. So go clockwise and then counter. Go clockwise. Yeah. Kidney, I think. So go counter. So we're way too far. I think we may be in like distal bulb. Let me just, I just want you to look at my hands when I do this, okay? So, aorta, that means I need to pull back. So I just gently start spinning clockwise, and there it is. And this one, so right here. So look at this. Relaxed, supporting the shaft of the scope clockwise, counter.
Right.
Clockwise, counter. So I'm not even like grabbing the
No.
scope with my right hand. Bile duct, pancreatic duct at the bottom. And now you can see the mesenteric vessels too for staging purposes. But again, it can be not so clear sometimes. Because there's your SMA at the bottom, and V would be right behind the mass, except it's not very obvious to me. This is SMV, and this is SMA. And if you want to,
Cellular material of the,
you want another one?
I think you need to get
Sure. I don't know how to, what, so the things you can change are to have less suction because it's getting very bloody, or zero suction, and do a stylet pull only, or even without the suction, just do FNA, which we may do. इस दफ़ा suction ही on करेंगे, उसके बगैर ही कर लेंगे.
अच्छा ये जो आप ये करते हैं ना move,
This is the stylet outside. मैं निकाल के आपको दिखाता हूँ कि हाँ. This is how far your needle is going to come out. Your needle sheath is going to come out.
right.
And so this is the sheath right up here.
Right.
This ये है sheath.
इसका मतलब purpose क्या होता है? To protect the
हाँ कि you don't want it too deep in, you don't want to perforate through, and you don't want it too far out back कि वो आपकी needle जो है, it has to travel a long distance before it can actually get to the tissue of interest.
अच्छा मेरे रिपोर्टिंग है तो वो he puts this on stop as well ना. Is that to protect के आप
Yes, you don't go too far. I tend not to do it, but yes, that's the idea. Yeah, कर ही लेते हैं, just don't know. It goes out of plane. So इसमें I did do 2 different planes, but I took the needle out all the way. So yeah, I want you to try and do this. Just don't worry about the endo image.
Right.
Get here,
right.
and it's just loose movements.
Right.
All you're doing is you're spinning. Thumb is not too far down in this position. So try and maintain the scope position, and then and do that. Hanji. Okay.
I think you're taking one more pass?
We did one.
That should be good.
Okay. Yeah, I'll take a look.
Suspicious, that's all I can say when I'm not sure. It looks like
Yeah.
this side.
So,
I think
but irregular shapes, I mean, I think
they are
they're enlarged.
they're large, they're spaced very.
Yes.
So some features there, and there's more than one bunch actually.
Yeah.
So just focus on one for now. Sir? Done, that's it.
Can you come? I'd like to move on.
Yeah, we should be fine.
Yeah. Okay. Challenge Janab. So I think we have enough. How about we do mediastinum?
Right.
And then we can get this wrapped up. Okay, so one good point, evaluate the liver. Make sure we look for Mets. I mean, that changes her, staging, of course. So, so once you're in G junction area, go clockwise. So yeah, and not from there. Here. There you go. That's it. And then this is just supporting. That's
Right,
it.
fine.
And now go the other way. Okay, now here you do have to face the patient more. So there, this, and then section, and then there, and now you can spin over to the right. There you go. You have your liver with section and come towards you. Yeah. Good. And now left hand up. There you go. There's your liver. Excellent. That's your liver coming to you. Now spin it all the way till you lose sight of it. So spin all the way. Now go clockwise all the way the other way. Keep going, keep going, keep going. Because you're evaluating the liver as much as possible. Okay. There's your IVC coming in.
Yeah.
Now you can go. Now you can go the other way. Back the other way. That's it. And you can pull back and do the same, so you see a different plane of the liver. Okay. Spin, 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 spin. The other way. There you go. That's it. That speed is good. You want to just keep moving forward, right? So there is a hepatic vein going into IVC, and then that's it. Okay, pull back now, and let's see if we can see the left side of the heart. So go counter, because we're more rightwards. There you go. Now you're starting to see the heart beating. So pull back some more. Keep pulling it till it's in your field of view. Keep pulling. There you go. Okay, that's IVC. So that's right side.
Yep.
Right atrium. And now go clockwise. Okay. Go the other way. Counter. It's okay. Keep going counter. Keep going counter. Keep going. Keep going. Drop your hand. Keep going all the way. There we go. Okay. So now now you start seeing recognizable structures, right? So I will test you. What's this?
That's the mitral valve.
Yeah, mitral valve. So left atrium,
Yes,
mitral valve, ventricle, and then show me the aortic arch.
That's the aortic.
Yeah, so go clockwise a bit. And there's your aortic outlet
Yeah.
going into the aorta. Beautiful.
That's right, yeah.
And then up here is where you want to look for the nodes. So
Right.
pull back and spin over that a bit. There, pull back some more. Right there is where your
That's the
four
subcarinal.
subcarinal level 7
Right.
in terms of numbering. Okay, good. Now go counter and find the aortic root. Aorta, the descending aorta there. And now as you come back,
Yeah.
you're approaching the arch. Once you see that the aorta is coming to an end, it's arching, you can stop. Big wheel towards you, advance a bit, and turn clockwise. And that will give you your two eyes.
Aorto,
Yes,
pulmonary,
exactly. So aorta, pulmonary artery,
and aortopulmonary.
yeah, 4L, which is technically left lower paratracheal, and 5, which is your aortopulmonary.
Right.
Okay? All right, good. Let's come out.
Right, thank you. That's
Good.
fine.
And then there are other smaller
Yes.
vessels. Of course.
Still not bit clumsy, is it? But
No, you're not. You're fine. माइक ऑफ कर दें ज़रा